In the past 6 months, around 20% of patients in Jersey's emergency department could have used another service, and the department recently put up a sign encouraging islanders to consider pharmacies, GPs and the out-of-hours GP. I, Megan Davis, sat down with Dr. Masha Finn, clinical lead and consultant in emergency medicine, to talk about life in the emergency department, why people come in with chest pains on Boxing Day, and of course, why she wants islanders to know about alternative services. Masha, thank you so much for taking the time.
That's fine.
Could you just start by introducing yourself?
So my name is Masha Finn. I'm the clinical lead for the emergency department and I'm consultant in emergency medicine. And I've been here permanently since for about 18 months now.
And could you introduce the department really briefly, give me an idea of the kind of thing you do and maybe a bit of a day in the life?
So we have a really lovely department. We see about 45,000 patients a year. So it makes it sort of small to medium size in a sort of bigger scheme of things. We have a resuscitation department with 3 spaces in it. We have 8 cubicles. We have pediatric waiting room, pediatric room, and a separate minors area. And the minors area is staffed with doctors and emergency nurse practitioners who are fantastic. And we see a huge variety of patients from, heart attacks, strokes, people falling off ladders, car accidents, to children who come in with cough, worried parents, to, ankle fractures or sort of minor injuries. So it's quite a range of conditions that we can deal with in the department.
Yeah, absolutely. How many sort of staff and patients would you see in a day?
Staff-wise, we have the template is 6 nursing staff on each shift, and then the doctors-wise, normally Monday to Friday. So the middle grade staffing is consistent 7 days a week. So we have 4 middle grade doctors on a day, including a night shift. Consultants, we will have 3 or 4 consultants overlapping their shifts, and then there's quite a few junior doctors as well.
Could you just explain the difference between those roles? I'm not sure that people know.
Yeah, of course. So the junior doctors are the ones that have finished their medical school and they've done their first year of doctoring normally on the ward, and then they come to us. There are clinical fellows who are doctors who finished their what's called foundation training, which is the first 2 years after medical school, and they come to us because they want to get more experience in emergency medicine. The registrars are senior doctors who have done probably 4 to 5 years of working in emergency medicine, and they they see patients and they make decisions and they advise on care for junior doctors. And consultants are doctors who have done their training in emergency medicine, who've passed the exams and have sort of achieved the, nirvana of medicine, of becoming the consultant. So they're sort of the most experienced people on the shop floor.
We know that the hospital as a whole has had staffing issues, recruitment issues. Do you find that there are particular pressures around emergency, or is it actually a department that does quite well?
So we have been really quite lucky because in the last sort of 18 months, the rotas have been changed to make it more consistent with cover for the department. We have managed to recruit more consultants and more registrars and junior doctors into posts who previously would have been covered by agency staff or bank staff. So as a whole, our department is doing reasonably well with staffing. We still have some outstanding vacant jobs, so we're interviewing for more registrars this afternoon. But as a whole, I think we're well staffed for compared to what it was like even 2 years ago.
What have you done to improve that?
I think what we have, because the road has been changed, so there is a lot more support for certainly junior doctors on the shop floor from consultants and registrars. So more people want to come and work in the emergency department because they feel that they're well supported, they get trained, they get taught in different skills that they want to learn. And from a registrar's point of view, recruiting into registrar posts the same, because the consultants are in the department working from 8 a.m. to 10 p.m. Monday to Friday. So there's a lot more clinical supervision, and they feel that they are not left to their own devices, so to speak.
Gotcha. Is that people coming over from other departments, or maybe coming over from the UK?
Some people have come from UK. Some people who used to be locums have decided to take permanent posts because they feel they're valued and they get training and progress. So I think it's just making people understand that they can progress in their job.
Yeah. How many locums and agency staff have you got at the moment?
In A&E,
Yeah.
none. So there are some bank shifts to cover sickness.
Yeah.
That are mainly junior doctors, but we don't use any agency staff.
Wow.
But that's for doctors. And as far as I understand, the nursing complement's been recruited to numbers, and all agency nurses have been given end date, and the last agency nurse is leaving in the beginning of February, so there won't be any agency nursing.
That seems like a really positive.
It is really positive, yeah. It's really encouraging.
Yeah. Now, wanted to go back to. I know you were asking people to come in only if they have a genuine emergency. Could you give me an idea of the kind of issues that you were seeing that actually just put a strain on the system and didn't really warrant coming into A&E?
Quite a few people come because they run out of their prescription and they don't ring their GP to renew it. And it makes it really difficult because we are there to see everybody who comes through the door. We don't turn people away. We might offer them different solutions, but we don't criticize people for coming. So if somebody comes asking for a prescription renewal, we can't do it because we don't have access to their records, and we wouldn't be prescribing the medication. We don't know their history. It's just not good clinical practice. In the summer, quite a few people pop in to get a checkup before they go on holiday, which is somewhat funny. Some people have conditions they've had for quite a few months, but they haven't spoken to their GP, and then they come to us because they feel it's a quicker option. But that also is counterproductive, because if we see them, we're really good at managing acute conditions and emergencies. Long-term conditions need follow-up, they need follow-up tests, they need follow-up reviews, which we can't provide. So whilst we might tell them that they are well today, we will still tell them to go to their GP to get follow-up. Yeah, that's sort of a short summary.
Do you know if there's been any analysis of why people might come to you rather than to their GP for issues that really would be a GP?
So when people come to the ED, majority of them feel it's an emergency, even though I wouldn't classify it as an emergency. People feel they have no other option. So that's why the sign is there, to just educate people that there are other options. It might not stop them from coming in when they are there, but maybe next time it will make them think, well, actually, I can go to the GP, I can go to the pharmacy, I can ring the out-of-hours doctor for telephone advice, which is, £20. So it's not that cost prohibitive. And also just to let people know that there is loads of other things happening in the background. So the waiting room is quite isolated. People don't see the ambulances coming in. They don't know that somebody's collapsed. They don't know what's going on in the major part of the department. So they get frustrated. They're not being seen quickly, but they don't have the perspective of what else is going on.
How do you handle the triage aspect of that? How do you get through people?
So there is anybody who comes to A&E gets triaged by an experienced nurse. And there is a set criteria that we use, which are used around the world. It's called Manchester Triage, which highlights people who are not well, which highlights people who might have abnormal blood pressure or pulse, and they're put into categories. So P1 is immediate response needed. So they are normally the patients who come in with blue light ambulances because they're really unwell. P2 is somebody who needs to be seen quickly. P3 is somebody who should be seen, probably within an hour. They have something wrong with them, but not life-threatening or life-changing. And P4 is somebody who could wait for a couple of hours. So P4 would be somebody who twisted their ankle. They can still hobble, unlikely to be fractured. They're in a bit of pain, but they still need to be assessed to see whether they need an X-ray.
Mm. And final question on this sort of what's a genuine emergency thing. How do you handle asking people to be sensible and not scaring them off coming to the emergency department?
So like I said, we don't turn people away. We might, one of the examples, somebody came in with an earache, I think last week, and the triage nurse rang their GP who said they can see them at, 2 o'clock, and it was 10 o'clock in the morning. The patient said they don't want to go, they want to be seen in the ED. So they stayed and they waited for some time. So we offer people options, but we don't turn them away. We never say, we will not see you. We are there, we're open 24/7. We're there to see essentially anybody who comes through the door. I think we're trying to educate people that if you are not a priority, you will be waiting for quite a long time, and it might be better if you find an alternative option, because that would be quicker. But if you want to wait, that's fine. It just will be some time.
Can I find out also what's the current sort of average waiting time? What's the upper and lower end of the scale?
So you're talking about patients in the waiting room?
Yes.
Or patients? So in the waiting room, it all depends on whether it's a busy day, it's an afternoon. Some people get seen within 10 minutes. Some people might wait for maybe 2-3 hours to be seen. I think that's probably the longest. If anybody is waiting for more than 4 hours, it's an exceptional circumstance, and we might have had a major presentation in majors, a couple of ambulances at the same time, and everybody's been rerouted to look after those patients. But I think probably on average, I don't actually have definitive numbers, but I would say 1 to 2 hours waiting is probably the average. Yeah.
And how do you quantify what does good look like in that aspect? And are you hitting that target?
Well, so the targets are for P4 patients, they need to be seen within 4 hours, and I'm pretty certain majority will get seen within 4 hours. I think we just need to realise that even somebody who is in the waiting room, who's been triaged as can wait, sometimes things change, and if they develop new symptoms or if they become unwell, they will get seen before somebody who's been waiting longer. So if anything changes, those patients will be prioritised. So that extends the waiting time for somebody else who might not need to be there in the first place.
That makes sense, yeah. Coming up to Christmas and New Year's as well, is that a particularly busy time for you, and how do you prepare for that?
So it gets, just before Christmas gets really busy because schools are shut, loads of ice skating, loads of falls, loads of sporting activities. So there is quite a lot of injuries, but equally with winter, there is big rise in respiratory illnesses in kids and adults. And elderly patients might find those respiratory illnesses really overwhelming because the immune system might be weakened. So admissions with pneumonias and other respiratory infections are on the up. Christmas Day normally is quite a good day to work because staff are happy, even patients who come in are reasonably happy, decorations out, there's lots of food. But the Boxing Day then becomes another really busy day because GP practices are shut. People have eaten too much at Christmas. And then there's, people sometimes come in to get checked up for things they might have left unchecked for a couple of weeks because they wanted to get to Christmas. They wanted to get through the Christmas dinner and the presents. Yeah.
What kind of thing would that be?
You know, ironically, some people have chest pains that they've left because they dismiss their symptoms, and then at Christmas they have a chat to their family, and their family say, well, that was really silly. So then they come in, headaches, just different things. It's well published phenomenon, especially in countries that are quite religious. So I worked in Ireland before, and in Ireland there's a lot of patients try to get to Christmas, and they have sort of Christmas with their families, and then they deteriorate because that was their sort of end goal. So anything, Boxing Day is quite busy.
So it actually makes more sense to miss Christmas at home, come here, work.
Well,
Christmas
it's not about me. It's just if anybody doesn't feel well, we're here. It doesn't matter that it's Christmas. We're still open. We're still staffed. We're here to look after anybody who feels they're not well and they need seeing. But just ironically, that does not happen.
Yeah. I wanted to ask about. There have been issues previously with people coming into the emergency department with mental health concerns. Is that still an issue, and how are you handling that?
When you say issues, what do you mean?
Yeah, this is sort of what we were told, was that it was becoming a problem that people were coming in with mental health concerns and they shouldn't really be coming.
So I would disagree with that statement. Emergency department is open for anybody with any presentation they feel is an emergency to them. Patients with mental health are patients. It's a different condition, but they're still patients. So if somebody is at a crisis point, they absolutely should come into us. I think staff find mental health patients more challenging because of different behaviours that might come with mental health illness, but we have a really good mental health liaison team support. We are getting better at making sure that patients with mental health illness don't have a medical problem at the same time. So I don't see... I would disagree that we have a problem with patients with mental health illness.
I think that would be really good to hear, actually. Is there anything you wanted to add? Anything that you want people to know? Just
we are genuinely open 24/7. We have experienced staff on, and if somebody feels they are not well and to them it's an emergency, of course come to us. But the sign is there. I just want to reassure people, the sign is there to give people options, to make people think of what other services they might access. And I just don't want people to feel frustrated or upset that they're waiting for longer. If they're waiting, it means they are well. Because if we bring them straight from triage into majors, that's something to worry about, rather than sitting in the waiting room.
Yeah. Just talk people through those alternative options.
Well, so people can go to the pharmacy to ask for advice and any treatment. Pharmacists are trained in giving sort of advice in minor conditions.
Is that any pharmacy?
Any pharmacy. Their own GP is a really useful resource, even if they want telephone advice. And if the GP feels that they can wait until tomorrow for an appointment, that's probably okay as well. Out of hours GP, I appreciate there is a cost attached to it, but the telephone advice that out of hours GP provides is £20. Quite a lot of people ring emergency department for telephone advice, which we cannot provide. We are not trained nor insured to provide telephone advice. GPs are. So that's another thing that people find frustrating, because they ring, they wait for hours, not hours, but they wait for ages for somebody to answer the phone, and then all we can tell them is we are unable to give you telephone advice, and that makes people cross. So pharmacy, their own GP or out of hours GP is the way to go.
When people ring in for advice, do you just send them to either come in person or ring their GP? Or
so we tell them we cannot. It's sort of a standard phrase that now everybody's using. We can't give telephone advice, unfortunately. If you feel you are unwell, come to us. If not, you can speak to your GP.
Gotcha. And what's your priority? What are you sort of thinking about, worrying about at the moment?
Me personally,
Yeah.
about my children and their Christmas present.
Well,
that's
that
all.
Thank you so much.
No
for
problem. I
taking the
hope
time
you
to
have
speak
lovely
to me.
Christmas.
You too. Have a lovely Christmas.
Okay.
Thank you for listening to the Bailiwick Express podcasts. If you liked what you heard, please do follow us and keep up with the latest news on bailiwickexpress.com or by reading our sister publication, the JEP.